Hello, I'm Peg Bulgioni, Communications Specialist with Rutland Regional Medical Center, and I'd like to welcome you to Window on Wellness. We're pleased to have Dr. Mark Jacob, pulmonologist with Rutland Regional Medical Center, joining us to discuss lung cancer awareness and their comprehensive lung cancer screening program. I'll be back with Dr. Jacob after this message from Rutland Regional Medical Center.
I'm Tom Hubner, President of the Rutland Regional Medical Center. The Rutland Regional Medical Center is the largest community hospital in Vermont. We started back in 1896. We had 16 beds, 8 physicians, 1 nurse. This past year, we took care of nearly 250,000 patients, and we have 1,600 staff, 258 doctors. We are here to serve our community in every new way that is possible with this promise to you. We listen, we respect, we care, always.
Welcome back. I'm very pleased to welcome our guest today on Window on Wellness, Dr. Mark Jacob, pulmonologist with Rutland Regional Medical Center. Dr. Jacob, welcome to the show.
Thank you. Glad to be here.
And so we're going to be talking today about a couple of things, lung cancer awareness and also the lung cancer screening program that's available at Rutland Regional Medical Center. So I think let's just get started because we've got a lot to talk about. And so I think first and foremost is, what is lung cancer?
So lung cancer is when our normal body cells, or cells in our body, become unregulated. They either forget to stop growing or they forget to die. And then they accumulate and divide and become disorganized, and they no longer continue the function that they originally started out.
So what are the symptoms of lung cancer?
The problems with the symptoms of lung cancer are, they could be anything from a cough, which a lot of us have in the wintertime, to chest pain, bone pain, coughing up blood. Those are the alarming signs. Unfortunately, those symptoms are very late. I brought a friend along with me, and if you could imagine this is your right lung, we could have a cancer growing in here and we wouldn't know until it bumped into something hard like a rib and we had chest pain, or maybe ate into a blood vessel, and then at that point in time it's invaded or gone beyond just the lung, so it's not a early stage cancer anymore. It's more advanced, and so we cough out blood, or by the time it's symptomatic, it's usually a pretty late stage.
And I know there's been a lot of controversy about what causes lung cancer. Maybe you can highlight some of those things for us.
Certainly. The biggest cause of lung cancer is smoking. There's a distant second, which would be radon exposure. Other types of radiation exposures can cause cancer. And then the environment. Pollution in the environment can cause cancer.
And I know environmental issues I think people are paying attention to that a lot more closely. So I think that hopefully people are taking steps now to make things better for folks so they're not exposed to, what about asbestos? I mean, would that be another? Yeah,
so certainly asbestos used to be, but fortunately its use back in the 60s and 70s has been curtailed significantly. And it's been taken out of the schools and homes, and it's not as prevalent as anymore. But the state of Vermont has an asbestos mine, a former asbestos mine up in the North Country.
Really?
So
wow.
Yeah, not very many. It was closed a long time ago, so
right.
Not very many people know about it.
Now, what about lead? Would that be a causal?
Lead isn't necessarily a cause for lung cancer. Certainly, the biggest impact it makes is in children, and for their developmental stages and brain development.
If a person quits smoking, I mean, does their lung tissue regenerate?
That is, we like to think that, well, this is the story. So after about 30 to 35 years of age, that proverbial term downhill happens for lung function. When people get their lung function tested, or when we test the general population, after about age 30, 35, everybody's lung function, whether you're a smoker or not, starts to decrease. When you're smoking, or while you're smoking, that decline in lung function is anywhere from 3 to 6 times faster than a non-smoker. So what happens is when you quit smoking, that rate of decline, or how fast your lungs are getting worse, becomes normal. So you lose approximately 50 milliliters, like a quarter of a cup of lung volume each year. But you have liters and liters of lung volume when you're 30, 35. And so it's not a big deal. But the smokers have, for the years you have been smoking, the damage has been done. There's nothing that's going to make you 35 again. And so that's the misnomer. A lot of people are around, well, if I quit smoking, I'll get better. You'll get a little bit better, but you won't get back to your age-appropriate lung function.
What about asthma? Is that a contributing factor to lung cancer?
Asthma is not necessarily a contributing factor to lung cancer. We know that cancer is related to what we call oxidative stress, like we eat all these vitamin E and pomegranate juice as antioxidants. We know that the mere process of burning energy, burning fuel, using oxygen in our bodies causes what we call free radical damage, and that disrupts the DNA, and that predisposes people to cancer. So inflammation can cause cancer. Asthma is triggered by things in the environment that cause inflammation. So can I say asthma causes cancer? Not really, but some of the triggers that make asthma worse can cause cancer.
And COPD?
COPD is another pollution, dust-related lung disease, and usually it's the cause of the COPD that is the risk factor for lung cancer.
Is lung cancer hereditary?
There is a genetic component. If you think about it, our inborn mechanisms for life, we have DNA repair mechanisms that detect when a cell goes haywire, and it gets deleted and reabsorbed and recycled. So if you genetically have a predisposition to not be able to make those repairs quickly or efficiently, then that predisposes you to lung cancer or any type of cancer.
Yeah. I think most people think in their minds that folks that get lung cancer, I mean, there's that direct relationship with smoking, which I know you just said, but there's other factors as well. And it always surprises me, you know, when I hear of folks that have never smoked in their lives getting diagnosed with lung cancer.
Certainly.
Yeah.
And that happens very regularly, up to 30%.
Yeah. Is there a certain demographic that seems to be more prone to lung cancer?
Certainly. So it's the demographic or racial profiles it's really interesting. African Americans and Native Americans have a higher predisposition to lung cancer. Caucasians are kind of in the middle, and then Asians and Latinos are lower. Now, if we smoke hard enough, the differences between races goes away. I'm not saying we should smoke ourselves to equality.
No.
Those are probably genetic differences in just how our bodies are able to absorb and cope with the oxidative damages that we experience in life.
Right. And I know that it's important, you know, to find it early. And I think there was a graph that, you know, you had shown us about the various stages of,
Right.
of
So-
cancer.
So we brought, there's a graph on the screen that you can see, and if you think about the green lung that I brought out, stage 1 is a very early stage of lung cancer. It hasn't gone anywhere outside of the lung. It's still relatively small, and survival is really good. We have a really good chance of having a surgical care, and the average person lives far more than 5 to 6 years. Whereas if, you know, you're coughing up blood or you have some chest pain, by that point in time we're at stage 4, and we know that almost nobody's going to survive beyond 5 years. When we think about lung cancer or breast cancer and colon cancer, people don't usually die from those types of cancers anymore. People do die, but not nearly as many, and we've made a vast amount of progress over the last 50 years. In lung cancer, we have not moved that bar of survival more than a couple of percent in the last 50 years of medical science.
What do you attribute that to? Is it they're putting more research into breast cancer, colon cancer, or?
That's a difficult subject. There is that stigma of smoking, and oh, you know, you did it to yourself. There is that. It is also, like I showed early on, if the cancer is at an early stage and we've only been screening for the last 5 years, we don't find it at the earlier stages. We have always, more than 80% of lung cancers diagnosed today are diagnosed at stage 3 or higher. So we don't have that opportunity to cure lung cancer. And so we don't have very many lung cancer survivors, and we can't have parties and races and marathons.
But and then this kind of goes to what you're trying to do right now with the lung cancer screening. So this is kind of a nice segue into that, because that's your objective, or that's your mission, is to try to catch it early and encourage folks to come in and get screened.
Right.
I mean, do they have to be, they don't have to be symptomatic, obviously, or is there, I mean, I know there's a certain profile of an individual that should come in and get screened, and why don't you tell us a little bit about that?
So screening is, it's you know, you can live without your colon. Lung cancer screening is complicated. You can live without your colon. You can have a radical mastectomy and still go about your life. It's very difficult to live without your lung. And so lung cancer screening has had lots of challenges to try to figure out who the right person to screen is. So between 2004 and 2009, there was this big trial, and tens of thousands of people were screened. Dartmouth Medical Center was one of the major centers for where the data was processed. So it's nice that we have regional experts close by. And for people who are otherwise healthy and not symptomatic, so not coughing up blood, they can, you know, they're out running, they're doing whatever, they have absolutely no symptoms, and they're not going to die from any other cause. Those people benefit from going and having a CAT scan every year or so, a low-dose CAT scan where we try to limit the amount of radiation, because radiation causes oxidative damage, and then we start that vicious cycle again. Those people who have smoked for 30 pack years and they're 55 years of age, they're asymptomatic and they're not going to die from some other cause. They benefit if we detect cancer early, and they benefit by screening them.
Okay. Is this your visual aid?
Yes.
Explaining some of that, how it works,
So,
your loaf of bread?
Yeah, certainly. Let's get Lenny the lung up. So if we look at a chest X-ray, we have to look through the whole lung, and we don't necessarily see our lung cancer. It has to get pretty big before we can see it. What we do with lung cancer screening is we go through a special CAT scan, which is a reduced dose of radiation. And what that does is it makes the pictures just a little bit suboptimal than the high dose radiation scans, but it's not terrible. And we take you and we slice the lungs like a loaf of bread. So I have a loaf of Wonder Bread here, and smokers generally have abnormal lungs, and they might have a small 2 millimeter or 3 millimeter nodule, or density is really what we have to call it because we don't know what it is. And we would say, you have a small abnormality on your CT scan. It's too small to do anything with. We're going to rescan you in 12 months. But if it was a little bit bigger, then we would say maybe we need to do some more imaging, or maybe send you to a surgeon to see if we cut it out or get a biopsy of it, and then decide what we can do. But if we did that, then we have found you before that has eroded into the bone around your lungs or eroded into a blood vessel, and before you've been symptomatic. Because remember, this person was asymptomatic. They weren't complaining of any pain or coughing or anything like that.
So I know that we have another graph that kind of illustrates the cancer. I guess these are numbers from the Foley Cancer Center.
These are numbers from the Foley Cancer Center. So these are people from our community. This is our home. These are our friends and neighbors. And what we're trying to do, if you look at the graph, there's the number of cases on the left-hand side, and then along the bottom is the stages. And if you look, stage 4 on the far right-hand side, that most of the cases are there, more than any of the other cases put together. And what we're trying to do is we're trying to flip this graph. We want to find lung cancer at stage 1 or stage 2 where we can treat them or cut it out surgically. If we can cut, if we remember that curvy graph with all the curves on it, if we detect it at stage 1, we can cut it out. We have the greatest chance of curing your cancer and you having a healthy rest of your life. Unfortunately, our data from the Foley Cancer Center in our area, it reflects national norms, which is most lung cancers are detected late. So the urge to do the lung cancer screening is to really try to find the cancers earlier so that we can do something about it.
Right. Well, and that's kind of your call to action. I mean, that's what we're trying, what the hospital is trying to do, is to try to reach out to the community and let them know that this is available and to encourage folks to come in and take advantage of it.
Yeah.
So, then the graph will be flipped,
Hope
hopefully.
to.
Yeah.
So we just looked at the 2016 data, and we are finding that we're getting diagnosing more cancers in the community, unfortunately. But we are getting a few more in the earlier stages, so that's encouraging. We're hoping to really see a shift in the coming years.
So if folks are interested and want to have a lung screening, a lung cancer screening, how do they go about it?
So one of the best ways to go about it is the American Lung Association. If you have access to the internet, search for Saved by the Scan. If you think about the old TV show Saved by the Bell, well,
okay.
We're going to be saved by the scan.
Okay.
And that will give you a guide, a little quiz to see if you're eligible or not. So if you've smoked in the past, if you smoked more than 30 pack years, and that is, if you've only smoked half a pack for more than 30 years, or you're 60 years, that's still 30, adds up to be 30. Or if maybe you did 2 packs a day for 15 years, that's still equals 30. And you're 55 years old, and you're either still smoking or your last cigarette was less than 15 years ago. That would be somebody that should talk to your primary care physician and say, hey, you know, I think I might benefit from cancer screening. What we do at Rutland that we're kind of proud of is if you're still smoking, we're going to talk to you about smoking, give you some counseling. If you need patches, gum, lozenges, whatever, we want you to, you're making one healthy choice to get screened. We want you to make the next healthy choice and quit smoking. We know nationwide that participating in lung cancer screening does help people quit smoking, because it changes. You're starting to make decisions now to take better care of yourself.
Okay, excellent.
So.
All right. Well, that's excellent information, and thank you for joining us here today. And so now we're going to go live to the pulmonary center at Rutland Regional to show folks what a live demonstration of a lung cancer screening looks like.
The referrals made for the lung cancer screening program by the primary care physician, the patient's primary care physician, or our pulmonary physicians. The appointments are scheduled through the pulmonary clinic. Once the appointment is scheduled, the patient arrives. They come for what's called a shared decision-making appointment. We are required to have that appointment prior to the CAT scan being done as part of an insurance requirement.
Hi, come on in. I'm Kim. I'll be working with you today. We're going to get your height, your weight first.
So when a patient arrives, we do what's called a Tamamagi score. It's a lung cancer risk score that we do to provide a risk assessment for whether or not they are appropriate to participate in the program. The score involves getting information about a brief history, whether or not they have a history of lung cancer in their family, whether or not they have a personal history of cancer. We ask them basic questions about height, weight, age. The patient has to be, in order to participate in the program, between the ages of 55 and 77. They have to have a smoking history of at least a 30-pack year. They have to be willing and able to participate in the program and undergo possible procedures like biopsy or surgical intervention. They have to be non-symptomatic for lung cancer at this point in time. You know, lung cancer is the leading cause of cancer deaths in the United States. And the reason, you know, it's not that it's more prevalent, it's just by the time we find lung cancer, it's in a more advanced stage. So the goal of the program is to screen and scan early so that we can find smaller, you know, nodules at an earlier point to provide earlier intervention.
So after the shared decision-making appointment, we go through prior auth department to make sure that the patient will have this test covered. We then schedule the CT scan. The patient will arrive. There's no contrast needed, no IV needed, and the patient is put on the scanner, and usually only on the scanner table for maybe a minute or two. The technologist will ask them to hold their breath and let it out, and then they're done. They can go home. People say they're scared of the CT machine itself. It's often confused with an MRI machine, which has a longer tunnel, and you're in that scanner for a longer period of time. For the CT scanner, you're basically traveling through a donut, and it is really much, much shorter of a scan. You're only in the machine for a few minutes, and you make a couple of passes through. The technologist will ask you to hold your breath and let it out, and then you'll be all done. So we're looking for a very small nodule. They can be as small as 1 millimeter or 2. We have a computer program that aids in picking up these nodules, because this CAT scan is less radiation than a usual CAT scan. So when we think about medical radiation, we want to use the smallest amount that we need to do what we want to do. With the aid of a computer program, we can give less radiation to pick up these nodules. They're not the same as a diagnostic CAT scan, which you might get if you came to the emergency room for symptoms of pneumonia. We are just looking for these nodules here. So the computer-aided diagnostic piece works with the radiologist to pick up nodules that we would normally not see because of the minimal amount of radiation that we're using. Because the computer program is able to aid with this, we can then classify these nodules based on a standardized system that's used across the country and help risk stratify patients so that they know when their next follow-up scan should be. Once we have the report back from the radiologist, we then look at the interpretation, and if the patient doesn't need to come back for a year, we call them and let them know their results. We send a copy of the results to the person who ordered the scan, and then we just put them back in to be rescanned in 12 months. If something is needed that is more follow-up, either because the nodule's a little bit bigger or something else is concerning, follow-up could be as soon as 3 months or 6 months, and we would speak to the person's ordering provider to let them know so that they can have that conversation. This sort of program is important because it's not the first scan that's going to help save lives. It's the follow-up scans, so we know exactly what patients' lungs look like, and if something new crops up, we can be ready to attack quickly. The first scan is a baseline, and any nodules that were already present are just going to be tracked. We don't want patients to avoid coming in because they're worried about what they'll hear, because whatever is there is there. We want to catch it before it's symptomatic to give people a better chance at survival.
Thank you for joining us today on Window on Wellness. You can watch us weekly on PEG TV Channel 15 or on demand at pegtv.com.